This is Quick IM with Dr. Aid. Today, we will discuss insulin therapy in type 2 diabetes mellitus. This video is for educational purposes only.
Type 2 diabetes mellitus is characterized by insulin resistance and progressive beta cell dysfunction. Many patients eventually require insulin therapy for glycemic control. Insulin remains the most effective agent for lowering blood glucose and preventing complications. Indications for insulin therapy include A1C levels over 10% or blood glucose above 300 mg per dl, regardless of other treatments or stage of the disease. Other indications include symptomatic hyperglycemia, acute illness, pregnancy, marked catabolic features, and hyperglycemic emergencies. Types of insulin used in diabetes management include rapid-acting, short-acting, intermediate-acting, and long-acting. Examples include Lispro, Aspart, Glulisine for rapid-acting, and Glargine, Detamir, Degludec for long-acting. Each type serves different purposes in managing diabetes. Here we see a detailed comparison of insulin types including onset, peak, and duration. Rapid-acting insulins such as Lispro, Aspart, and Glulisine act within 10 to 30 minutes to control postprandial glucose spikes. Short-acting regular insulin has a slower onset within 30 to 60 minutes and is used for mealtime coverage as well as intravenously in emergencies like diabetic ketoacidosis. Intermediate-acting NPH provides basal coverage but carries a higher risk of nocturnal hypoglycemia. Long-acting insulins such as Glargine and Detamir deliver steady background insulin for up to 24 hours with minimal peaks, making them preferred for basal therapy. Ultra-long-acting Degludec offers stable control for more than 42 hours with reduced hypoglycemia risk and flexible dosing. Premixed insulins combine basal and prandial components in a single injection, offering convenience for patients with fixed meal schedules. A1C and glycemic targets differ for outpatient and inpatient settings. For non-pregnant adults, the general target is A1C below 7%, with preprandial glucose between 80 and 130 mg per dl and postprandial glucose under 180. Tighter goals, such as an A1C below 6.5%, may be reasonable in younger or healthier patients if achievable without excessive risk of hypoglycemia, while older adults or those with significant comorbidities may have a less stringent goal of under 8% to prioritize safety and reduce treatment burden. In hospitalized patients, insulin is initiated if blood glucose exceeds 180 mg per dl in critically ill patients, with a target range of 140 to 180, while for non-critically ill patients the recommended range is 110 to 180, though targets may be relaxed in those with severe comorbidities, terminal illness, or high risk of hypoglycemia. Insulin regimens include basal insulin, basal-bolus regimens, premixed insulin, and intensification strategies. Next, we will look at the current ADA guidelines on insulin therapy in type 2 diabetes before looking at each regimen in detail. The slide provides an overview of current guidelines for insulin regimens in type 2 diabetes mellitus. Insulin should be started if A1C exceeds 10%, glucose is above 300 mg dl, or if symptomatic hyperglycemia is present, with a typical total daily dose of 0.4 to 1.0 units per kilogram per day. Basal insulin is the preferred initial choice at 10 units daily or 0.1 to 0.2 units per kilogram, while other glucose-lowering agents should generally be continued unless contraindicated. If A1C remains above target on basal insulin, a GLP-1 receptor agonist should be added, and if goals are still unmet, prandial insulin is introduced, starting with a single dose with the largest meal before advancing to multiple doses. GLP-1 receptor agonists, including dual GIP-GLP-1 agents, are our preferred over insulin when there is no evidence of insulin deficiency. Next, we will look at insulin regimens in more detail. Basal insulin regimen is the most common starting approach in type 2 diabetes management. It involves a once-daily injection of a long-acting insulin such as Glargine, Detamir, or Degludec, with NPH as an alternative given twice daily. The clinical use includes patients with inadequate glycemic control on oral agents or GLP-1 receptor agonists, those with marked fasting hyperglycemia, individuals presenting with symptomatic hyperglycemia, and hospitalized patients or those experiencing acute illness. The rationale is that basal insulin provides a steady background level of insulin that effectively controls fasting hyperglycemia and helps achieve stable overall glucose management. According to ADA guidelines, basal insulin is usually started at 10 units once daily or 0.1 to 0.2 units per kilogram per day, taken consistently at the same time, with some patients requiring twice daily dosing for better control. Dose titration is guided by fasting glucose levels and typically involves increases of 2 to 4 units once or twice weekly until fasting glucose targets of 80 to 130 milligrams per DL are reached. Overbasalization can occur if too much basal insulin is given, leading to large bedtime to morning glucose differentials, hypoglycemia, or high glucose variability. If A1C remains above goal due to postprandial hyperglycemia, or if there are features of overbasalization, adding a GLP-1 receptor agonist is recommended before starting prandial insulin. The main advantages of basal insulin include simplicity with once-daily injections, lower hypoglycemia risk compared to premixed regimens, and ease of combination with other agents. However, limitations include less effectiveness for postprandial spikes, the need for intensification in some patients, and the potential for weight gain and hypoglycemia, though these risks are reduced with modern analogs. The Basal-plus regimen involves adding rapid-acting insulin before the largest meal of the day in patients who have controlled fasting glucose on basal insulin but persistently elevated A1C due to postprandial hyperglycemia. If one injection is insufficient, the regimen can be intensified to cover 2 or 3 meals, effectively transitioning to a basal-bolus approach. Initiation typically involves lispro, aspart, or glulisine at a starting dose of 4 to 6 units, 0.1 units per kilogram, or 10% of the basal dose, with titration by 1 to 2 units twice weekly based on postprandial or pre-meal glucose levels. The advantages of this regimen include stepwise intensification without committing patients to full multiple daily injections, making it easier to adopt. The basal-bolus regimen is designed to mimic normal physiologic insulin secretion. It involves using basal insulin to cover fasting and between meal needs, while bolus or prandial insulin is used to control post-meal glucose spikes. It is always required in type 1 diabetes and is also indicated in type 2 diabetes when A1C remains uncontrolled despite basal insulin with oral or non-insulin agents, when postprandial hyperglycemia is the main contributor to poor control. It is also indicated in cases of severe hyperglycemia with catabolic features such as weight loss or ketosis, and in special situations like pregnancy or hospitalization. Advantages of this regimen include its closeness to physiologic insulin replacement, flexible mealtime control, and effectiveness in patients with high A1C and significant postprandial excursions. Disadvantages include the need for multiple daily injections, an increased risk of hypoglycemia, especially if meals are skipped, common weight gain, and the requirement for frequent glucose monitoring and patient education. The basal-bolus regimen, which typically begins with a total daily insulin dose of 0.4 to 1.0 units per kilogram per day, split into approximately 50% basal insulin, such as glargine, detamir, degludec, or NPH, and 50% bolus insulin, divided into 3 pre-meal doses using rapid-acting analogs like lispro, aspart, or glulisine. The goal is to achieve pre-meal glucose levels of 80 to 130 and 2-hour post-meal levels below 180 milligrams per DL. Titration involves adjusting basal insulin by 2 to 4 units every 3 to 7 days to reach fasting targets. For titration of prandial insulin, fixed prandial insulin titration involves adjusting mealtime insulin doses by 1 to 2 units, or about 10 to 15% based on pre- and postprandial glucose. Flexible bolus dosing uses the insulin to carbohydrate ratio and insulin sensitivity factor for personalized adjustments. Carbohydrate counting allow insulin to better match food intake. A common fixed estimate for insulin to carbohydrate ratios is that 1 unit of rapid-acting insulin covers about 10 to 15 grams of carbohydrate. The rule of 500 refines this by dividing 500 by the total daily insulin dose, giving the grams of carbohydrate covered by 1 unit of insulin for more individualized dosing. Supplemental or correction insulin is added when pre-meal glucose is above target using insulin sensitivity factor. A common fixed estimate for insulin sensitivity is that 1 unit of rapid-acting insulin lowers blood glucose by about 50 milligrams per DL. The rule of 1800 individualizes this by dividing 1800 by the total daily insulin dose, giving the expected glucose drop per unit of insulin. This proactive approach avoids relying solely on reactive sliding scales and instead integrates correction into individualized regimens. This slide compares fixed estimates of insulin to carbohydrate ratio and insulin sensitivity factor with the more individualized rules of 500 and 1800 for flexible bolus dosing. We will use the example of a patient with a known total daily dose, or TDD, of insulin, about 60 units, pre-meal glucose of 100 milligrams per dl above target, and a 60-gram meal. Using a fixed insulin to carbohydrate ratio, we assume that 1 unit of rapid-acting insulin covers 10 to 15 grams of carbohydrate. For a 60-gram meal, 60 divided by 10 or 15 comes to about 4 to 6 units. The pre-meal glucose is 100 above target, and since 1 unit of glucose lowers glucose by 50, corrective insulin dose is 100 divided by 50 comes to 2 additional units of supplemental or correction units. This brings the total bolus is 6 to 8 units. With the rule of 500, the total daily dose is used to calculate carbohydrate coverage more precisely. Dividing 500 by a TDD of 60 gives 8 grams of carbohydrate covered by 1 unit. For the same 60-gram meal, 60 divided by 8 is 7.5 or about 8 units. Using the rule of 1800, a patient with a total daily insulin dose of 60 units has an insulin sensitivity factor of 1800 divided by 60, meaning 1 unit lowers glucose by about 30 milligrams per dl. Since the pre-meal glucose is 100 above target, correction insulin is calculated by dividing 100 by 30, which is about 3 units of additional correction insulin on top of the mealtime bolus, bringing the total pre-meal bolus to 11 units. Premixed insulin regimens combine intermediate-acting basal insulin with rapid or short-acting insulin to provide both fasting and prandial glucose control, making them useful when oral agents plus basal insulin fail to achieve A1C targets, particularly in patients with predictable meal schedules who prefer fewer injections. Common formulations include 70/30ths NPH with regular insulin, 75/25ths lisproprotamine with lispro, and 70/30ths aspart mixes. Dosing typically begins at 0.3 to 0.5 units per kilogram per day, divided into 2 injections with the classic approach giving 2/3 in the morning and 1/3 in the evening, though a 50/50th split may be used for balance. These regimens offer advantages such as fewer injections, convenience in resource-limited settings, and support for patients struggling with complex regimens, but disadvantages include inflexible meal schedules, higher risk of nocturnal hypoglycemia, weight gain, and lack of flexibility in adjusting basal versus bolus insulin separately. Titration is guided every few days by fasting and pre-meal glucose monitoring. Severe insulin resistance is defined as the need for more than 2 units per kilogram per day or over 200 units per day of insulin to maintain glycemic targets, and it is commonly caused by obesity with visceral adiposity, medications such as steroids or antipsychotics, endocrine disorders like Cushing's or PCOS, lipodystrophy, and rare conditions such as anti-insulin antibodies or receptor defects. Management begins with lifestyle optimization through weight loss, physical activity, and dietary modification, while also addressing reversible secondary causes such as tapering steroids or treating underlying endocrine disorders. Pharmacologic support includes the use of insulin sensitizers like metformin, GLP-1 receptor agonists, SGLT2 inhibitors, or TZDs when tolerated. Insulin strategies focus on concentrated insulin formulations such as U500 regular, U200 degludec, or U300 glargine to reduce injection volume, with consideration of continuous subcutaneous insulin infusion in select patients. In advanced cases, bariatric surgery for severe obesity or investigational therapies such as leptin and lipodystrophy may be required to achieve adequate control. Insulin is the preferred treatment for type 2 diabetes and gestational diabetes in pregnancy because it does not cross the placenta, is safe, flexible, and effective in achieving tight glycemic control, which helps prevent macrosomia, neonatal hypoglycemia, congenital anomalies, and obstetric complications. Oral agents like metformin and glyburide may be used in select cases, but are limited by placental transfer and uncertain long-term safety. Glycemic targets are stringent, and A1C below 6 to 6.5% if safe. The basal-bolus regimen is standard, with NPH or detamir as basal options, and rapid-acting analogs such as lispro or aspart for prandial coverage. with insulin requirements increasing progressively across trimesters from about 0.7 to 1.2 units per kilogram per day. This summary of insulin initiation and titration covers various regimens, including basal, basal-plus, and premixed. Each has specific indications, initiation protocols, and titration methods. Advantages and disadvantages are highlighted, helping tailor treatment to individual patient needs. Hypoglycemia on insulin therapy is defined as blood glucose below 70 milligrams per dl, with severe episodes requiring assistance from another person due to altered mental or physical status, and is more dangerous when levels drop below 54. Risk factors include intensive insulin regimens, irregular meals, advanced age, impaired renal or hepatic function, alcohol intake, and a history of severe hypoglycemia. Clinically, Whipple's triad is used for diagnosis, which consists of symptoms such as tremor, palpitations, sweating, anxiety, confusion, blurred vision or seizures, documented low blood glucose, and symptom resolution after glucose correction. Management of mild to moderate hypoglycemia in conscious patients involves the rule of 15, with 15 grams of fast-acting carbohydrates, rechecking glucose in 15 minutes, and repeating if still low, followed by a meal or snack, while severe cases in altered or unconscious patients require glucagon injection or intravenous dextrose in a healthcare setting. Preventing recurrence requires reviewing insulin regimens, meal timing, and activity, with basal insulin dose reduction for fasting or overnight hypoglycemia, and adjusting bolus insulin for postprandial episodes. Prevention strategies emphasize patient education on meal consistency, self-monitoring, recognition of early symptoms, use of basal analogs with lower risk than NPH, dose adjustments in renal or hepatic impairment, and avoiding overly strict glycemic targets in elderly or high-risk patients. Insulin therapy, while effective, is associated with several adverse effects that require careful management. Weight gain is common due to the anabolic effects of insulin and reduced glucosuria, which may worsen insulin resistance, and this can be mitigated with lifestyle modifications, combination therapy with metformin or GLP-1 receptor agonists, and avoiding unnecessary high doses. Injection site reactions such as pain, erythema, or local allergy can occur and are best managed by rotating injection sites, using proper technique, or switching insulin types if persistent. Lipodystrophy, including lipoatrophy or lipohypertrophy, results from repeated injections in the same area and can be prevented through education on site rotation and the use of shorter, finer needles. Hypokalemia, especially with intravenous insulin, occurs as insulin drives potassium into cells, necessitating electrolyte monitoring and supplementation when appropriate. Edema and fluid retention may present as peripheral edema or worsen heart failure, though this is usually self-limited and managed with dose adjustments. Insulin antibody formation is rare with modern analogs, but can occasionally affect absorption, sometimes requiring a switch to human or analog insulins. Other rare effects include potential cancer risk, not definitively proven, and insulin allergy, both of which require specialist referral and symptomatic management when severe. Monitoring and safety in insulin therapy involve regular glucose checks and A1C monitoring. Adjustments are made for illness or lifestyle changes. Continuous glucose monitoring is recommended for selected patients. Early initiation and individualized therapy improve outcomes and prevent complications.
For more educational content, like, share, and subscribe to Quick IM with Dr. Aid. Your support helps us create even more valuable content for you.